are no more concerns, we can start the debate. Prime Minister.
Okay, cool. Hi, everyone. Want to check that I can be heard?
Yes, you're audible.
Awesome. All right. Just give me 2 moments and I'll sort my notes out and I'll start. And one quick note, I'll take your words in the chat. Okay. Prevention is the best medicine, and under OG, we're going to tell you that the rise of decentralized healthcare system is great insofar as it gets people to be more proactive about their health. This probably leads to better outcomes for their health. That it also is probably cheaper for them, and it's fantastic. We're incredibly proud to propose for this motion. Okay, what am I going to do in my speech? Firstly, couple points of setup about what we think this is going to look like, about what decentralization of healthcare is going to look like. Then I'm going to talk a bit about why we think there are currently some problems in terms of access with centralized healthcare system, and therefore I'm going to talk a little bit here about what we think the counterfactual is likely going to be. Then I'm going to be bringing you some substantives about why we think that the quality of this decentralized healthcare is going to be comparable, insofar as this role is supplementary to I think other ways of accessing the healthcare system, and why this is going to lower the burden that this is placed on traditional and conventional systems of healthcare. Okay, then. So, couple points of setup I want to do first here. I mean, so I think the thing I want to note here is that this is not going to be something which wholly replaces, primary healthcare and having access to things like your GP or the hospital. Like, obviously, if you're involved with a terrible accident, you're still probably going to go to the you're probably still going to go to the hospital. If you're feeling stuff like chest pains or any other sort of extreme, extreme symptoms, you're still probably going to go to your GP or your clinic to get this sorted out. Therefore, what we're going to tell you is that decentralized system isn't going to be a replacement for primary healthcare as much as it's going to, I think, be something which happens alongside it. So therefore, I think the comparison in this debate then, I think the question you have to ask then is whether or not we think the presence of this alongside, being able to access the primary health system is a good thing. Now, what does this look like? So we don't think that, well, I think the Infoslide does mention things like over-the-counter medicines and being able to access those things. We don't think it's like wholly sort of self-medication. We don't think it's wholly going to be like self-medication at all. In fact, we posit that this is probably like the biggest change is probably going to be a mindset change. Like insofar as people are likely going to be more proactive about their health. We think given the rise or prevalence of decentralized healthcare system, this probably looks like more people being empowered to find out things about their health conditions, about symptoms, and about things they should be looking out for, and like certain signs about their health that they should be paying attention to. So this looks like being included about what certain symptoms may mean. There's the potential that you've got a certain illness or disease, or it could mean that certain things about your body may be early warning signs for certain diseases that you maybe want to look out for. So we think importantly this is probably a mindset change. People will probably access over-the-counter medicine. They're still probably going to ask at the counter, like when you're at the pharmacy and talking to the pharmacist, they're probably going to describe, I have some of these symptoms. Do you have anything which you could prescribe for me, and so I can sort this stuff out? Sort this stuff out. So we think it's going to be a high degree of I think increasing the proactiveness in how people approach health. I'll take that point of clarification.
So what exactly are the kinds of, say, policies or initiatives that will cause this mindset change you talk about?
This is not a policy motion. We just simply support the increase in decentralization of it. Come on, UNSW, read the motion. Okay, then. Let's talk about what the let's talk about why some problems with centralized healthcare right now. And I think the thing to recognize here is that it's just pretty expensive, and I think hard for a lot of people to access centralized healthcare right now. I think because of the barriers that are put in place right now. And I think the biggest thing here is probably just cost, right? And you see this all over the world. I think with just a general cost of living crisis, but I think also the levels of austerity which many countries around the world are going through, as well as increasing privatization, which we're seeing with systems famously like the NHS, as well as sort of health insurance burdens which are being placed upon patients in order to like access the healthcare system, it's just kind of expensive to go to the doctor. And I certainly know, growing up in New Zealand, even though we say we have universal healthcare, going to the GP and getting a consult is pretty expensive. It's like $70-$90, and that's not like easy money for you to like be throwing around there. So like I think already there's this I think cost is a significant area to why people aren't accessing like centralized healthcare already. But I think secondly, there's probably just like a lot of confusion about how to navigate the healthcare system, right? Like insofar as healthcare kind of is a complex space with many moving parts. It's probably the case that you don't like know the exact workings of your like district health board and what exactly you're entitled to, not entitled to for funding. I certainly can't tell you, and like my previous elections about like the district health board wasn't something I unfortunately paid too much attention to. So like I think those are some of the reasons why it's going to be hard to access. I think what therefore that means then is that likely the counterfactual is when you have a niggle and something comes up with your health, you're probably going to ignore it. You're probably going to think, no, I can like walk this off, or I can like sleep this off because it's going to be really fucking expensive to go see the doctor or go see the GP to get this sorted out. And we think this is going to lead to like further complications for your health because you don't treat the conditions which you need, and it's going to be more expensive and worse for your health because that little niggle is going to develop and it's going to be like way worse when it turns into a condition. Okay, then. So why then is decentralized healthcare system decentralized healthcare going to be going to be good? Okay, then. So I think the first thing to say here is like you're just going to be more aware, I think, of this, like, because you're going to be aware and you have knowledge about what's going on, you're probably going to be more empowered to, I think, find out, further things about your health, and you're going to be in a position where you are, I think, significantly, like, I think, invested at a higher level than you were already before to, like, keep an eye out on things like, are there any sort of, like, risks to my health, which, like, might be, a sign of, dementia or whatever other sort of health conditions have you further down the line that might develop, that might be a problem for you, that might be a problem for you. So, and I think recognize that we're not saying that this replaces the primary healthcare system. So if the case that you do find something and you flag it and it turns out it is going to be a problem, the fact that you're able to like sort of go to the doctor early and like get that sorted and get the medication early prevents it from becoming like more of a serious threat to your health, but also probably makes it cheaper because you're further along, you're further back in the like diagnosis of the timeline, and you're able to get the care that you need to stop it from turning into a big thing. But there are also probably some benefits here as well. That flow on here in terms of like the general health benefits for everyone. Like insofar as I think we lift the burden that is currently placed on healthcare systems right now, given that they've been kind of fucked by huge COVID numbers. We think that like not only do you like prevent serious illnesses from happening, but also if you alleviate the burden that you're already putting on these hospitals, you're just going to like get better healthcare. People have to access it more quickly and get a better quality of care when their staff aren't sort of overwhelmed by people turning up with like random trivial diagnoses. Okay, because we give like healthcare, we hand it over to people and put it in their hands and give them control of it. We think when you get to see better health outcomes, incredibly proud to propose.
Okay, thank you, Prime Minister. Leader of Opposition.
I don't mean to fearmonger in this debate, but this is literally a government team who wants to pump kids full of things like Ritalin, or allow people to access more dangerous drugs, or support the rise of like healthcare TikToks telling people what to do when they get a little bit sick. And this team is quite cowardly because the thing they do and run away from in this debate is defend the worst possible thing which can happen is the increase of OTC drugs, which is why I think this team probably just does lose the debate outright. Before then, let's do some rebuttal. Their first claim is we shift mindsets because prevention and awareness is super important. Number one, this isn't unique to decentralization. It literally happens under creditable healthcare systems. For example, often people will tell you to get STI checks every month or so if you're sexually active. Alternatively, to get breast cancer checks every 2 years to ensure that you haven't gotten any breast cancer parts growing in you. This is what already exists, unclear what changes with sort of decentralization. Secondly, they go, it's so expensive right now, therefore people just sleep it off, and that's really bad. Firstly, sometimes it is actually a good thing to sleep it off, because if you have a cold, there isn't a treatment. The thing you do is you sleep, you drink some honey lemon water, and you have some Panadol, and then it gets better. But secondly, insofar as now you have access to more drugs over the counter, it means you can like eat something which you're not supposed to eat, which is like, isn't probably dosed, or actually has a bunch of side effects, which means sometimes actually on the outside, it is better to take it and sleep it off as opposed to under your side when you take a shitty drug. So that's kind of makes that access is really bad. Our claim is that access is imperfect but sufficient. Which is to say, this debate isn't just about the US, which is a shitty healthcare system. Many countries have nationalized healthcare system, whether it's the NHS in Britain, or whether it is Australia already provides things like like medical health insurance and coverage. And the reason why I do so is because this is politically popular and people have the political capital to implement this for 3 reasons. Firstly, because healthcare issues affect everyone, which is why people tend to be more empathetic. Secondly, it is because they recognize the randomness of like health afflictions happening, that it is out of your control, which is why people are willing to fund money in it so people are covered in cases of emergencies. And third thing Jesse said here is that people recognize quality of life and health is important to be happy. That is why we often do get healthcare funding. But secondly, insofar as this isn't true, I think healthcare access gets way worse on their side, because the way government subsidies and insurance operates is lots of people buy it. People don't need to use it, and that functionally allows these systems to fund people who are more poor if they do not actually fund people who are healthier. So, for example, rich people means that people who are poorer and on healthcare services are able to access drugs. The problem here is that when you increase this access to the extent that people can buy drugs all the time, people are always accessing kind of these healthcare services, it actually reduces the amount of money which insurance companies can pay out to help the poorest people in the world. First standard piece of argument: why pharmaceuticals get worse. Firstly, I think pharmaceuticals have massive incentives to make money under a system where decentralization occurs, because firstly, they want to make drugs more accessible and more like over the counter, so more people buy it. Secondly, they want to make drugs over the counter which are more addictive, things like opioids and painkillers, for the very reason that repeated consumption means they make more money. Thirdly, they also want to expand the products being offered, given the fact that things like health journalism are on the rise, given things that people are listening to kind of quack natural treatments, they expand the products offered, such as things like fish oils and vitamins, which aren't actually that useful, but are a place where people make money and are able to opt into, and they capitalize on this trend where information is becoming decentralized, and as a result, they can put forward more crack treatments. The second part of this argument is established why decentralization gives them the capacity to act in such pernicious ways. The first of which, there is no prescription gatekeeping these drugs, which are good or bad, from public accessing it. The second thing here is that it is easier to market, because currently under status quo, when drugs are prescription, you don't actually market people to take things like Ritalin, because only effective people can take it. But now, given that it is over the counter and more people can take it, you're likely to advertise more to a general audience, which is to say, Ritalin is good for ADHD treatment, but now people also advertise Ritalin as a study drug which anyone can consume, which is particularly bad. The other thing here is that it now reduces the cautionary signal which prescription often causes in order to protect people, which is to say, people recognize OTC drugs are comparatively less harmless compared to prescription drugs, but once you remove that, people are far more willing to consume these drugs which used to be prescription for a reason they deem it to be something which is more safe and deem it to be something which is not going to affect them in quite awful ways. That's why it's quite harmful. People now get drugs which they don't need and that has a bunch of deleterious health effects. Second argument, people are also likely to diagnose badly, which is why they don't access the healthcare benefits they want to claim. Why does this happen? Firstly, many diseases have the same symptoms, which therefore means like it's very difficult to diagnose unless you have any expertise. And the problem here is that even though they've got similar symptoms, they have different treatments. So for example, when you have a cold, you often take painkillers, but when you have a bacterial infection, you need antibiotics. If you misdiagnose it, you often get the wrong treatment. Secondly, misinformation occurs relatively proliferately, given that information is widely accessible online through things like WebMD, but also the rise of things like health journalism, or as well as family speculating about what is good or bad treatment, means that people are far more likely to get contradictory information, which means they do not actually get good advice. The third thing though here is that people often have confirmation bias, which is that I am currently sick, I am displaying some symptoms, so I'm just finding the closest disease which matches these symptoms, and I'm going to get the symptom which this page is likely to recommend. But the problem is you don't actually know if you have that disease, it's just what you're guesstimating yourself. Their kind of here is that this doesn't actually replace primary healthcare system, because people will still go and reach out to the hospital. But the first thing to recognize is, firstly, if this is true, you lose half the benefits you claim under your side, but also people are probably just going to defer to this as opposed to primary healthcare, because A, it is cheaper, secondly, it is more time efficient, and thirdly, it is along the general trend towards distrust towards medical communities, especially with the rise of COVID-19 and also kind of anti-vaxxer sentiment, means that people are likely to opt out of these traditional systems. CJ.
Yeah, larger availability does not mean any and all prescription drugs are readily available. If pharma is so exploitative, you still prescribe when you shouldn't, but it's far worse on your side when you're solely dependent on the system.
That's still going to be gated, but you have to support having more OTC drugs which may have health effects on people. That is still fine. We've been on the comparative. The impact of people getting incorrect treatments are a fewfold. Firstly, incorrect treatments often means that you obviously don't get better from your health or disease. But the thing is, incorrect dosages actually are quite important, given the fact that often medicine affects people in different ways based on your height, based on your gender, based on your fat concentration and things like that. It means that you often need a doctor to actually properly dose you. The problem is, if you do an OTC drug, you cannot get proper dosage because things are produced uniformly and regularly, which means even if you have the correct drug as a treatment, it often isn't tailored to you as an individual, which is why you do not actually get the healthcare benefits. The second thing to note here is also this obviously looks like people not following through with doctor's instructions, so not finishing a full course of antibiotics and causing a superbug crisis. That seems bad. That is why I think it is bad when people individually diagnose. The last argument I'm going to make is why this undermines trust in doctors. Firstly, mechanisms as to why this is true. Firstly, when things become decentralized, healthcare becomes more subjective. There are many different solutions to a single problem, which therefore means it is able to support many different kind of ideas which are outside the medical consensus. The second thing here is just that direct marketing also is better able to exist, but you can tell people that to get this drug, you have the symptom, you can get this drug, means it is likely to be far more pernicious. The impact is threefold. Firstly, this is obviously worse because you should trust doctors more because they have training and expertise as compared to you as an individual. The second thing to be said is that people will also, this is also the very mechanism as to why people advocate for the reduction of regulation. For the very reason that if there is many different ideas and many different medical consensus as to what is good, it therefore means people often advocate towards having more choice, which means lowering standards, allowing more drugs to be accessed in the field, and allowing people to choose what drug they want to fit their treatment. And that is quite bad because that means more drugs get through. Very proud to oppose.
Okay, thank you, Leader of Deputy Prime.
Hello, can I please check if I can be heard?
Yep, you're audible and visible.
Thank you. I got diagnosed for ADHD last month. Before I did, it took me 2 hours to get up some days and 3 hours on others. I could not get my schoolwork done for weeks because I constantly put it off. It took me $400 Singapore dollars to get diagnosed as a student and 6 months of consultation. Abhor the fact that opposition bench assumes that my inability to recognize my own symptoms, because even my ability to know that if Ritalin is going to hurt me, then I will probably be able to make that decision-making calculus myself and realize that, hey, Ritalin is hurting me right now, that probably the state will probably warn me about all of these things. I think that opposition bench fundamentally takes an incredibly parental and controlling view of the individual. In my speech, I'll prove 3 things. Firstly, whether or not decentralized healthcare systems are good and will be improved in the future. Secondly, whether currently existing centralized healthcare systems are good or will be improved. And thirdly, a principal argument about autonomy and the right to self-defense from healthcare systems that have failed you. Firstly, whether or not decentralized healthcare systems will be good. We would argue that yes, at this point in time, it might seem like decentralized healthcare systems are bad, where MD is currently inaccurate. Government bench agrees completely. However, notice that when there's an increasing number of people who opt into WebMD and an increasing amount of individuals who opt into it, there are strong central incentives and strong capacities to make it better. How so? The point at which larger amounts of people opt into it is the point at which researchers which develop drugs realize that, hey, if a lot of people mass marketing our drug towards, take it and realize that there are horrible side effects and inaccurately take our drug, that's the point at which our drug sales will plummet and our shareholder prices will plummet as well. That's the first structural reason why this probably won't happen. The individuals are not going to do that as well, or do that and hurt themselves. The second structural reason is likely the state that has a stronger impetus to regulate these things as well. The point at which, for example, the opioid epidemic got worse is the point at which an American state was able to crack down on opioid epidemics and strongly regulate the sale of these drugs. We would argue that in that scenario, that President said shows that as increasing numbers of people opt into decentralized healthcare systems, there's larger amounts of both individual, market, and state incentives to be able to regulate your own drugs as well. But thirdly, people are strongly careful about their own health. They don't want to take drugs and spend money on drugs, which will hurt them, because these are things that unnecessarily people are often distrustful of, right? That probably means that therefore, the point at which you opt into a cost of medication is probably the point at which you take a lot of care before you opt into these things as well. We reject the characterization of opening opposition that individuals are fundamentally stupid, right? We would argue that for the most part, people care deeply about their own health. But the point at which there's an increase in decentralization is the point at which there's actually a capacity to regulate these things as well. But lastly, and this is super important, for the most part, the counterfactual is nothing. Notice that the point at which your individuals are unable to access healthcare at all is the point at which none of the benefits accrue, because their benefits are a comparative between a doctor and yourself. It isn't a doctor and yourself, it's yourself and a centralized healthcare system that more cares for you or nothing. That moves me nicely to my second issue. What is the counterfactual? Opening opposition asserts, not proves, asserts that there are currently existing universal basic healthcare systems around the world. We think that there are very, very limited states which actually offer this. Only in the Nordic states and New Zealand all actually offer universal basic healthcare systems. For the most part, healthcare systems around the world are either A, privatized, as in America, or B, privatized or public, but rather underfunded, such as the NHS, which famously has massively long waiting lines. The consequence of this, the reasoning behind this is because there's a massive healthcare industry and a strong amount of centralized healthcare industry that has strong amounts of lobbying power to keep themselves private as compared to giving it to the public domain, as well as an increasing amount of users. Because of COVID-19, as well as because of a massive amount, the sheer number of people who have diseases and only are able to get diagnosed by doctors, that's the point, and this is true for every disease, whether it's minor or major, it's the point at which you're unable to be able to access healthcare at all from this centralized system. The consequence of this, therefore, is that your ability as an individual to be able to get access to centralized healthcare is far, far little. Notice, they shift the burden on the opposition to prove that no healthcare is actually better at all. But then they told us that, they need centralization for economies of scale. And only with a large amount of people on insurance will centralized healthcare systems be able to function. To a certain extent, this is true. However, we would argue that most people still have an incentive to go on to insurance anyway, rich or poor. Reason being, you probably recognize that there are some limits as to whether or not what you can diagnose. So for instance, sure, you can diagnose yourself with a common cold, or you can get aspirin, for example, or Hex, but you cannot diagnose yourself with cancer. But everyone can get cancer, right? In all of these instances, you still have to be able to opt into insurance, especially if you are able to afford it. The debate, therefore, exclusively is about those who do not have access to insurance. Those who, if they got cancer tomorrow, or if they started feeling a leg pain tomorrow, given the amount of money that they have and the amount of meals that they escape, in a decision-making calculus, are going to have to make the painful decision of hoping there is nothing, and maybe even being forced out of the insurance because they're out of a job, right? And their insurance is tied to their jobs. All of these things ultimately mean that in opposition's world, it becomes far, far worse for these individuals as well. And the comparative for them isn't a centralized healthcare system, it is nothing. But furthermore, we actually argue that in our world, we improve healthcare outcomes for those who use centralized healthcare systems. Why is this the case? We agree that for the most part, healthcare is funded by states. That is to say, in the vast majority of states around the world, it is publicly funded, such as in the case of the NHS. This is going to be constant because the amount of tax revenue the state gets is constant on either side of the house. The crucial difference, therefore, is on our side of the house, those who go and use a decentralized healthcare system alleviate the burden of the doctors. This means that the ratio of doctors to patients and the amount of doctors on hospital beds and drugs to patients in centralized healthcare systems is far lower on our side of the house. That's when we actually get the ability for individuals who really do need doctors to see doctors more often. This co-opts the massive amount of benefits that opening opposition claims, because all of their benefits about doctors as being better for people, yes, we get those too. The comparative is on your side, those people who really needed doctors also are in the same queue as those who didn't really need doctors, and unfortunately might just be at the back of the queue and never able to see the doctor when they really, really need it. Then the healthcare outcomes worsen, and they then get hurt when for example, their cancer metastasizes and becomes form. I'll now bring up the principal argument. My argument is that actually individuals deserve the right to protect their own health in principle. Why is this the case? We would argue that in general, you have a moral right to self-defense. That's to say, you have the ability to defend yourself, for example, when someone physically assaults you or when someone physically assaults your family, etc. We recognize this, for example, when you do not charge people for committing acts of even violence of defense as well. We would argue that therefore, in this scenario, where the state has failed individuals by not providing them with adequate amounts of healthcare, they deserve the right to know about how they're able to protect themselves with increasing amounts of funding towards systems that can actually provide them with these things, right? When there's more and more health journals such as WebMD and competitors to WebMD that do it better, when there's more and more allowances for individuals to get drugs which are not necessarily harmful to them because that's where their R&D lies, that's the point at which individuals deserve this right as well. Notice that this is the right of individuals irrespective of how it affects society, in that if you as a person believe that you have a right to defend yourself, you also have the right to cure yourself, and that's why you deserve the ability to protect yourself in this instance. Therefore, so proud to propose. Thank you.
All right, thank you, Deputy Prime Minister. Moving on to Deputy Leader of Opposition.
Hey, can I be seen and heard?
Yes to both.
I don't think that speech ever explains why it is that the people who would take use of this decentralization through reading health journalism or through buying their own over-the-counter prescription medicines are stakeholders that would necessarily benefit from doing this, right? Because even if you take them at their best and believe that there's a group of stakeholders who currently do not have access to the kinds of treatments that can help them, they don't actually prove why the treatments that they do end up getting or the diagnosis they do end up making are ones that are beneficial for them. And Kat therefore explains a number of harms as to why it is the case that people will often misdiagnose themselves, or people often waste money on medicines that they do not need, or waste monies on the wrong kinds of medicines. And those are the kinds of things that will cause harms to people. I have 3 issues in the speech. Firstly, on the access to healthcare. Secondly, on the quality of healthcare. And lastly, on this weird self-defense principle. Firstly, on the access to healthcare. The reality of this world is that medicine and doctors are obviously very expensive. And that is why in almost no jurisdiction in the entire world do people actually just like pay for doctors or for like medicine out of their own pocket. Like it's not really a thing. And where it is a thing, that would just be what opening government is supporting, right? A world where it was entirely up to the free market, where you didn't have a centralized healthcare or doctor system that subsidized doctor visits or made it free for people, would just be a world that they support. So I don't think this debate is about context in which like it's full free market, because that's what occurs post decentralization. This debate is largely about places with some form of centralized healthcare system that does some ability to cater for the vulnerable and the poor. And what we explain at Leader of Opposition is that the mechanism through which the poor and the vulnerable are taken care of right now is that they are funded by the tribe, right? For a process of things like government subsidies or insurance, right? Like I don't think like the poorest people wouldn't be able to pay for over-the-counter medicine and stuff on either side. The way that they actually pay for over-the-counter medicine is because over-the-counter medicine is subsidized by the government, because the government recognizes that those medicines are important and particularly useful. However, this pool is obviously a very vulnerable pool, and this pool is one that goes through a filter. We know who is most vulnerable because the vulnerable people within this debate are the ones that are either able to go for a prescription because the doctor can say, yeah, you're suffering from this disease really badly, so you deserve a prescription. Or it is the case that they, are eligible for like insurance claim checks because, the insurance company can verify that their health is bad. Or it is the case that because they are below a certain income threshold, they can access the kinds of low income subsidies through programs like Medicare or Medicaid or Obamacare. The problem under their side is they essentially get rid of that whole filtering process because everyone can access these medicines. Everyone, can kind of get these medicines at cheap and all that kind of stuff. And that is why, yes, you can give some examples of people who use Ritalin who are really sympathetic examples. Like I'm sure there are loads of people on their side who would benefit from these medicine. Our claim isn't that those people aren't deserving of this medicine. Our claim is merely that there are a set of vulnerable people who are more deserving than other people. And those are the people that pass through those prescription checks and pass through muster currently. And the kinds of stakeholders that are able to access this medicine now raise the cost for those more vulnerable people. Because when more people access insurance claims, when more people abuse a subsidy or abuse doctor's visits, that's when the cost increases for the entire system. And that's when the most vulnerable are no longer able to access healthcare. So what that means is that on the point of access, our side is far better able to cater for the most vulnerable. Access wasn't just important of getting medicine to everyone. Obviously, we don't care if rich people can access medicine when they can otherwise fork out a lot of money for it. It's about getting money to the most vulnerable stakeholders, and we provide for those stakeholders. What are their arguments, responses to explaining why the harms that we talk about will not occur? The first thing they say is that there is a competition mechanism. If it is the case that, a company releases a dud drug, obviously, people will no longer buy from that company and that company will go down. This competition mechanism doesn't work because the medical space is uniquely uncompetitive. And that is for a number of reasons. Firstly, obviously, there is really strong lobbying and regulation around the production of medicines. For example, a company will have a patent and they'll produce a substandard drug. But even though that substandard drug might be bad, because there's no alternative, people are forced to purchase that drug. But also, people's purchasing habits don't always correlate with their interests. We explain at LO, for example, how companies can directly market to people through advertising to trick people into thinking that medicines are really important for them, like fish oil, but also in other cases, the important contexts we explain, such as opioid addictions. When people are addicted to a drug, they'll of course purchase that drug, but that drug is not good for them. And that is why that competition mechanism doesn't work, because that competition mechanism is dependent on believing that people buy things that are good for them. But we explain that in the medical industry, people overwhelmingly buy things that are not good for them. The second response is, well, there'll just be regulation. The first thing to say is they have to necessarily cop a short-run harm in order for that regulation to happen, which is like, you know, social battering ram. But the second thing is like their whole case about changing people's mindset is what depowers regulation, right? Because when people think healthcare as a system is more subjective, that people should have more choice, that the government shouldn't be as paternalistic, that's when regulation goes away, because people like the government shouldn't be telling people what medicine should be gated behind a prescription. The government shouldn't be telling people what standards to apply to the production of medicine. So regulation actually goes down under their side. They can't just be like, regulation will come in and fix all these problems, because their whole point and the whole case is that this regulation is bad. I'll take a point from closing. What's your extension?
Surely there's also greater pressure on the medical industry itself to respond, given the fact that a lot of people are opting out, as you presume, under opt?
So I think the medical industry more sensitively responds under our side, because they're the ones that are actually responsible for patients, right? So if a patient gets a prescription from a doctor and the doctor fucks up, the patient sues the doctor and the doctor's border, like, you know, we gotta clean these things up. That accountability doesn't occur on your side, because on your side, the patient just gets the drug, doesn't read the terms and conditions, and screws themselves over, and there's no one to answer for that. Secondly, in terms of quality of healthcare, we explain that you know, the awareness of symptoms doesn't necessarily mean that you actually identify what is actually good to do, because people usually aware that something's wrong with them because, you know, they're vomiting or they're fatigued. Under our side, people see a doctor. Under their side, they self-diagnose and self-treat. Like, people know that there's something wrong with them. It's about diagnosing whether that thing is a particular disease. But also on certain kinds of things where it's not obvious, it's unclear that they can self-diagnose these things effectively. But under our side, where healthcare is centralized, governments know that people have low capacity, and that's why they provide things like STD checks and all that. In terms of self-defense, like, I just think if their model fucks up, then it just hurts other people, it hurts the whole system, and also they're likely to ingest a medicine that is bad for them, so they don't fulfill their own principle. For these reasons, we are very proud to oppose.
All right, thank you, Deputy Leader of Opposition. Moving on to Member of Government.
Hi, can I check that I'm audible and visible?
Yes, to both.
Okay, great. I'll take POIs to the chat, so just send a message, and no preferred gender pronouns. Starting in 3, 2, 1. The reason why OO has to be out of this debate is that they never attempt to question why people are so quick to jump on a decentralized healthcare system. That for these individuals, their perfect alternative does not exist, because these are individuals that would have never turned towards your system in the first place. These are the individuals that feel like that is a healthcare system that discriminates and persecutes them and never takes them seriously. It's individuals that are scared of medical professionals and don't trust them. The distrust within the system and themselves means they never seek help. For them to just say that therefore our world is better because they don't turn to these alternatives is negligent to the actual reality of the world, where they self-medicate anyway, they seek unregulated treatments, traditional herbalist medicines, etc., and they never actually seek the help that side of opening opposition likes to assert they have. Before moving to extension material, a few levels of framing and rebuttal. I think first, it is fair criticism from opening opposition towards opening government that their problems are issues with access versus an actual defense of decentralization as beneficial. That this is highlighted as a lot of issues are solved with government intervention and regulation of the healthcare sector that waters down a lot of opening opposition, which I think is one angle that closing government is going to enter this debate in, which we're actually going to defend decentralization as a concept in general, assuming the levels of bureaucracy to an extent can be solved in the mitigation that opening opposition wanted to provide to you. But second, I think that note that things like over-the-counter access, even things like getting paracetamol and antibiotics in some countries is extremely bureaucratic, which I think is negligent of opening opposition to just assert it isn't the case. Because I think they wanted to go to the jump to the immediate extremes, where in instances where you increase access towards drugs, you have to necessarily increase it to the most dangerous, pernicious forms of drugs altogether. I think first we can still gatekeep some prescription of drugs if the ramifications are super, super severe, given that there's a scale of the dangerous drugs that currently exist out there, where some are more addictive than others and some have more severe side effects. It doesn't mean we have to legalize and create easy access to all of them, and means that prescription as a concept completely falls apart. But second, why isn't even addiction as important as a metric to weigh off in the first place? I think addiction is far more speculative of its harm and unnuanced to each individual person. But the suffering and the pain that you feel is tangible for the person right now. Having pain that makes living on the day-to-day hard is a valid concern for these individuals that does not meet the metric of going to the hospital, for example, to solve, and often they just need a painkiller, etc., to have. In those instances, the bureaucracy and the inability for them to actually seek and get easy medical access from over-the-counter drugs, where they would need to see a general practitioner in the UK, for example, to even get pain relief medication first, are things that are valid for individuals to actually seek in the first place. But the two brand new extensions with a lot of integrated rebuttal that I'm going to bring to you in this debate are twofold. I think number one, it's brand new material on creating a self-regulating healthcare system where traditional healthcare is challenged. I think it's completely different from what opening government talked about, because they focused on competition between drug companies. And I think this is far larger than that, but it's the entirety of the system. And I think this slots nicely into what was said in the last speech from opening opposition in terms of the competition in the system as well, that would directly engage. And second will be a defense of taking charge of your own healthcare. I think here OG mainly focuses on financial constraints as the main reason people need this decentralization. We think although that is true, we'll be the only charitable gov team and assume that government has some mechanism to solve it and increase access for the most financially destitute in those instances. That is how we'll enter this round, and that's how we'll take this debate. On to the first thing, on the brand new material on creating a self-regulating healthcare system when traditional healthcare is challenged. I think first, the premise here is that assuming the absolute worst case opening opposition wants to push us towards, where individuals misdiagnose and die. Everyone is now a drug addict over-the-counter drugs, and everyone drinks ginger tea that a health magazine told them instead of getting help. Those are the exact reasons why governments are forced to improve the current system that exists to encourage participation in traditional healthcare. I think it is amplified in the highly Americanized context that opening opposition also wanted to operate in, where it's highly privatized and things like the opioid crisis happened. I would note that that's highly isolated in instances where it's highly privatized and the government does not have control over a lot of the distribution of the drugs or the way in which regulation exists because of the big pharma lobby. But even in that instance, I think it's far greater here if there's a profit incentive and people turn away. You create a competition mechanism within the entirety of the system. Three things that you're likely going to solve. I think number one, if the main issue was accessibility, then that's what we're going to solve. We're going to make it far easier. We're going to reduce the admin costs and the administrative costs for people to receive help in the first place. Or the level of treatment that you're going to provide to individuals is going to be made more accessible, opening up more clinics near individuals if the problem was transport or getting there, etc. Accessibility is what we'll solve. I think this is far greater contribution compared to opening government, given that they just outline a problem, but they never wanted to actually create tangible outcomes and solutions in the end. Because I think on closing government, we're far more nuanced. We think that self-medication and taking charge of your own healthcare is important, but we don't think this discounts the importance of traditional healthcare as well in certain instances that we will provide. Second, if it's bureaucracy, that's something we'll also improve. If it's individuals on long waiting lists that are unable to get help and seek help, we'll create more, we'll solve bureaucracy easier. That is an issue. If it's discrimination of individuals, particularly women or people of color, that is something we'll improve in patient protocol and procedure to restore trust between individual consumers and the hospital and the traditional healthcare system in the first place. The conclusion is that even in our worst form, we create a feedback system that will eventually end up helping the most vulnerable of individuals and create a system that people can trust. But in our best form, I think it complements the kinds of acts that individuals have. It reduces the number of individuals that have to go to the ER or the emergency room insofar as they're able to seek some level of alleviance on their own. Before I move on, I'll take a point from opening.
Allowing more people to access these drugs and making the healthcare system more subjective gives up the tools of regulation, which means that your feedback mechanism doesn't actually work. What are the actual regulations you can get on your side when you've given up the tools of regulation?
You should engage with probably more than one part besides just one individual instance. But we told you that's exactly why. I don't think any government wants to create an opioid crisis, nor does anyone want to just nor does anyone seek one not to receive the best level of medical help if they can help it. Insofar as we create a better system, reduce bureaucracy, make it easier to access, I think you solve all of those things. I think therefore that is clear, and the competition mechanism should be highly valued within this round. But second, in actual defense of taking charge of your own healthcare. Note panel, we live in a reality where people of color are more likely to be turned away from doctors because people or doctors don't believe their pain is legitimate. A woman is likely to be diagnosed for the exact same disease 4 years later than a man. Instead of arguing just technicalities and semantics, we'll straight up defend these actual decentralized practices. We think self-diagnosis can be categorized in a few ways. I think either you self-diagnose and then seek doctors to treat that diagnosis, insofar as often for these individuals, you're turned away countlessly and you're not actually taken seriously. But second, if you self-diagnose and then self-medicate, I think either it works and they aren't in pain, in which case we think it's fine, but if it doesn't work, it means you'll default to medical professionals. On their side, you likely never see these alternatives altogether. On our side, you actually create a system that helps individuals and creates trust within systems.
Okay, thank you, member of government, member of opposition, you have the floor.
Hey, can I be heard?
Yes, you're audible.
Cheers. All right. I'm going to start my speech in 3, 2, 1. There are two. So opening opposition's case in this debate is essentially just these drugs might be bad. There are two large problems with this. First, they do absolutely no likelihood analysis to explain why the sets of drugs that they point out could be bad is the overwhelmingly likely set of characterizations. And secondly, the set of harms of why the drugs are bad rely on you believing that regulators are so stupid that they would, in fact, approve as over-the-counter drugs actively harmful drugs. And that's how closing opposition is going to win this debate. Our first contribution will be to explain why it is that the bad sets of drugs that clearly exist are the overwhelmingly likely characterization for this debate. And second is to explain why it is that these are actually harmful in a way that doesn't rely on the slightly implausible characterization that regulators are just so terrible. Let's start by explaining why the sets of things that this debate is likely to be about are likely to be bad. The first reason here is that the set of things that were good, because clearly, right, there's some set of decentralized healthcare that is good and some set of decentralized healthcare that's bad. My first observation is that the set of things that were good, there was already an incentive to provide before the recent rise of decentralized healthcare. Because the question is, what actually caused this rise? Because there has been some forms of decentralized healthcare for, the last century, but there has in the last 10 years been an extra rise in the amount of decentralized healthcare. And we would say the thing that has caused that rise is the capacity of the internet to deliver consumers to producers. Therefore, the sets of things that this debate is about are about the set of things that have been introduced to the market during the rise, not all sets of decentralized healthcare. And we would say that those are overwhelmingly bad, for the reason that the sets of things that were already good were already provided as decentralized healthcare before this rise, because there was an incentive on the part of medical professionals and the government to provide it. What that means is that the set of things that this rise is about are disproportionately likely to be the bad things. The second reason people are likely to opt into the worst sets of things is because they're most likely to opt into the things that have the simplest, most appealing narratives, that says this fixes everything, that says there is one solution that can fix all of your problems. But we would say that there is an inverse relationship between the simplicity and appealingness of the narrative that a drug is pushing and the actual efficacy of the medicine. That is for two reasons. First, because human bodies are naturally complex, there are distinctions. So if your narrative is very simple, it's likely a lie. And secondly, because there just aren't simple solutions to most things. And if there were, it wouldn't be a big problem. And the solution wouldn't be hidden on a dingy little internet website. It'd be known in the general public. Therefore, because people opt into the simplest things, and we point out that the simplest things are likely to be bad, that means that people are likely to opt into the things that are bad. Opening government's claim here is, this is about the developing world where there's no access to other medications. First, the developing world still has hospitals and a healthcare system. Like, yes, the developing world is poorer than the developed world, but it still does have a healthcare system. And secondly, presumably, if you were in the developing world, you were always relying on decentralized healthcare. So that is not what this debate, which is about the rise and increase in decentralized healthcare, is about. So they cannot talk about context in which everyone was already claiming this. I'd note here that this response to opening government of explaining why this debate is not about areas where there isn't access is a much better response than what opening opposition provides, and therefore that's an additional reason why you put us over opening opposition. What is the weighing on this? Because opening government says some things are good, some things you might be able to opt into well, some things are helpful. Opening opposition says sometimes things are bad, sometimes you won't be able to consent to. Both are plausible. It's unclear who wins that clash in opening half. CO makes it clear that this is an opposition bench win because we explain why the good things aren't the things that would be part of this rise and aren't the things that people are likely to opt into. That's why we've already won the round. Before I go on, I'll take opening government.
So your extension relies on us reading the motion as a retrospective motion. That's not true. The rise of decentralized healthcare is a general motion, including trends to the future as well.
Okay, but all my analysis still stands, right? Which is to say, before the increase or the rise or whatever, there's an incentive to provide the good things. The rise, as we identify the first team in the round to identify what caused the rise, is the commercial incentives. Therefore, they're the most likely to be the bad things. You also don't respond to the second reason I give, which is about how people opt into simplistic narratives. Second contribution is to explain why it is that this is actually likely to be harmful. Because it's hard to believe that regulators would approve something that is actively harmful. But what we explain is why it is that this is actually mutually exclusive to better things, which is how we generate our harm. Opening opposition's explanation of mutual exclusivity is, but now people are going to buy into anti-doctor narratives. This requires you to have an enormous amount of belief in the amount of effectiveness of these anti-healthcare narratives, right? Which is an enormous analytical burden opening opposition has to take on themselves in order to prove that, and I don't think they meet that. We provide a clearer explanation of why it is that it's mutually exclusive, which is that there's less incentive to subsidize the better prescription versions of these drugs. That is first. So the context for this is that most really effective drugs are expensive because they require an enormous amount of research. And therefore, in order to be accessible, they require subsidy. Why are we likely to get less subsidy for the actual efficacious prescription drugs when there's decentralized healthcare? First, there is an over-the-counter alternative, which is something that regulators take into account when they're making the decision of whether or not to subsidize a drug. And secondly, where there's an over-the-counter alternative, there's less backlash to not subsidizing the drug because people don't feel like they're being denied any medicine at all. But second, and more powerfully, when you have an over-the-counter alternative, the company that provides that over-the-counter alternative now has an incentive to lobby the government not to subsidize the more efficacious prescription version of the drug because it would eat into their market share. This is a better explanation of why it is mutually exclusive to traditional medicine than opening opposition. First, because it doesn't require you to believe that so many people buy into such an insane narrative. And secondly, because our mechanism of medicine not getting subsidized affects all sets of people in the community, whereas their mechanism, which explains why people might buy into a narrative, only affects the set of people who buy into that narrative. So we explain why this is mutually exclusive to traditional healthcare, far better than opening opposition. Our final contribution and the final reason why this is likely to be harmful is that healthcare is likely to be overused. That is to say that in decentralized systems, there's always a profit incentive to get people to use healthcare more, but you can't in a non-decentralized system because doctors are the check. But under our side, you can get people to use more and more healthcare. And this looks like telling people that they should use more of your particular drug. For instance, an aspirin a day keeps the doctor away, a narrative that was specifically pushed in the media by the company that sells aspirin. And that is when it can get harmful, because it is perhaps implausible to believe that a regulator would approve an over-the-counter drug that was actively harmful when used one time, but it's very plausible that they might approve a drug that is harmful when used correctly, but then the harm comes when it is not used correctly. The harm comes when they then attempt to coerce people into using it more. That is where you can get a realistic harm that a regulator would not check. Closing opposition wins this debate because we explain why, yes, sometimes it can be good and sometimes it can be bad, but we explain why the bad ones are the ones that this motion is overwhelmingly likely to be about. That is why we very, very clearly take the round.
We thank member of opposition for that speech. Go ahead.
Hi, can I just check if I'm audible?
Yes.
Okay, thank you. Okay, starting my speech in 3, 2, 1. Note that I heard not one single line of response coming from CO to the extension that Evan provides to you in this debate. The fact that the rise itself, especially in the new rise of, for example, whatever medication that they want to talk about, is exactly the pressure to ensure governments step up to the occasion and ensure that the current healthcare system actually is a viable alternative for people to opt into. The growing rise of people opting out of the system itself and the distrust that OpBench tries to talk about in this debate is exactly why governments are likely to step up in terms of, one, regulation on the advertising of these medicines in the first place, but secondly, also to reduce hidden costs and admin fees that people are greatly resentful of within the current healthcare system. 2 questions I want to answer in this debate. First, why is it that regulation on advertising is likely to be far greater under closing government? And secondly, on like lobbying and like making sure that the system is likely better. First, on the idea of regulation, this I think needs to deal with like part of the CO extension actually is quite overlapping with the OO idea of like the fact that we can't regulate over these kinds of medicines and we're unable to control narratives in the media precisely about offering great solutions to people. Firstly, I think OO is right in saying that OG is convenient in name dropping regulation but not actually explaining it. But I'll do so now. 1, I think in status quo, OP has been incredibly uncharitable with the fact that we currently do regulate big pharma with regards to like advertising, and we actually have standards with regards to like food and safety. We also have standards, especially regarding medicine. We don't have any of these advertisements that are largely like, for example, of a narrative promoting drugs, right? Even the Apple example coming from CO is perhaps a preventative measure that people actively took. And note that I actually think that it was a huge benefit from it, right? Like a lot of people did actively make changes to their diets and did, for example, partake in preventing themselves from having to opt into the medical system as a whole. But note that the regulations, I don't think we have to defend a drug epidemic for a few reasons. 1, I think the fear of consuming drugs that may worsen your present condition or cost more in the long run to fix later on is exactly why you would always err on the side of caution when you are unsure, or at least when you feel like this website is quite dodgy. And note that precisely because the rise or like the increased decentralization of this information exists, we are also likely to have very strong counterstructures that suggest that some websites are less credible than others. 2, I think big pharma can very much be sued, and this is something that neither op team wanted to entertain in this debate. Even if big pharma does get somewhat like more powerful through supplying drugs over the counter itself, I don't think it removes the capacity for them to be sued, right? Like for example, 1, if there is a very, very misleading narrative that makes people believe that this is a one-stop solution and it clearly is not, then I think there is a very good cause for people to sue big pharma as a whole, or at least there is a cause for governments to heavily regulate big pharma when they do slip up at all. If ads produced are completely misleading or fails to disclose fatal details like allergens or incompatibility, then I don't see why they can't be held accountable in these circumstances. And if anything, I think the rise itself is exactly the push that governments need to regulate big pharma with regards to its advertisements and its lobbying. But thirdly, I think the decentralization also includes doctors disseminating information on accessible platforms. Because let's not forget like the other half of this motion that neither op team wanted to talk about, which is the fact that there is a growing, for example, accessibility of other home remedies for an increasingly like large number of diseases that people currently get. So this means that historical examples of drug abuse and all the examples that OP can give us are presumably things people know of as well, and medical professionals can also greatly advise of, which means to say that's precisely why society would also be greatly advocating against any lies or at least like very misleading narratives when it comes to medical accessibility. What are the kinds of medicines that like the info slide then is likely to talk about, right? Because I think, note that this exclusive framing made in Evan's speech was completely unengaged with. 1, he said that it's likely to be paracetamols where the overuse is not exactly a huge risk, or any new drugs that come out, right? Like for example, if these things don't have the risk of overuse or at least like overconsumption to a very large extent, or at least there isn't that harmful of an effect if you could overconsume over like 1 pill, for example, that is also something we're likely to also support. But 2, this is medication that you've already probably got a prescription for, but the drugs are extremely rare in, for example, over-the-counter medicines, right? But you do have a prescription and you know that this is the type of drug that you're supposed to consume. The problem is that hospitals oftentimes force you to go there so they can charge you admin fees and a lot of hidden fees that are involved. Op's response is we don't pay for medicine out of our pocket. We have insurance. Like, I think whilst insurance subsidizes a large part of this like cost, it is unlikely to like, it is also a very huge barrier as to why people opt into the system at all, because they do have to pay, for example, one cut of it, and they're unwilling to do so. Note that I would flip their argument in terms of insurance, right, and coverage coming from both op teams, because this is exactly what makes systems a lot more cost saving if admin fees can be avoided where possible. If, for example, you can get the medicine that you require in over-the-counter areas, you're likely also to reduce, like, for example, coverage that the burden of coverage on insurance as a whole, which is also, I think, a good thing in terms of this. So their harm doesn't exist. But two, with regards to lobbying, right, and this is the only mechanism actually coming up from closing opposition as to say, oh, wait, before that, yeah, opening.
We provide a number of reasons why competition uniquely fails in the healthcare context, because people's purchases don't align with their interests. That is why opioid addicts perversely drive the increased production of opioids.
Okay, but the competition is not with like other companies, right? That's like OG's case. They can defend it. I don't care. But it's basically the fact that the competition exists for governments to make sure that this regulation is in place, which takes out a large chunk of the op case, right? Because if lobbying is something so pervasive and something that can exist, surely we would not create a system that where we are over-reliant on big pharma supplying all of the medicines that exist. Note that if opening opposition and closing opposition can preempt all the harms of like poor, like misuse, poor narratives that are being formed, why would the government buy into this system at all, considering the fact that they know that, like, to some extent, traditional like hospitals in general, or at least like traditional medicine, is something that is generally preferred by people? Like, surely people would buy this over WebMD if it was more accessible, which is precisely why governments know that there is a buying factor within sponsoring, like, for example, healthcare systems, or at least creating more subsidies that are available. But note crucially that the push in order for this to happen is uniquely coming from the fact that the rise posits a threat. Note that we don't have to concede all the harms of like very, very poor medication, because we think governments will respond adequately at the point at which they are forced to. And note that given that no team actually responds to this, we win.
Okay, thank you, government whip, opposition whip.
Which is a better. Hey, I'm going to start by checking that I'm audible.
Yes, you're audible.
Okay, cool. I'm just going to organize my papers, get my timer up. Give me 30 seconds. Cool. POIs in the chat. I'll probably take it about 5:30. Probably OG. But you know, we'll see. Cool. Starting this speech in 3, 2, 1. The first thing I want to do is just clarify what the extension coming from closing opposition is, because there's a lot of tactics in that government whip speech to muddy the waters by making this debate seem unnecessarily confusing and not actually addressing our extension, such as to make it seem like we didn't have one. Matt delivers 2 important pieces of context into this debate that win the round. The first thing that Matt explains is a piece of framing that breaks the deadlock and actually defeats closing government by explaining that everything that the government bank is attempting to do, which is the popularization of good alternatives, already exists. Matt demonstrates that where there is credible research backing up newer alternatives, where there is research and there is development to suggest that other forms of home medicine might be applicable in, you know, for example, relieving pain, there was already an incentive in the status quo, and there has been an incentive over the last 50 years in order to ensure that these things already exist and are fairly popularized, and that similar levels of treatment that have similar levels of scrutiny continue into the future. That means that any additional emphasis on the popularization of drugs that deviate from the norm in medical professions are likely to be bad alternatives. And the second piece of extension that Matt provides is to say that this screws over not just people who would opt into this, which is just what this debate is concerned about at the present point, but everyone, because the way that subsidization gets allocated is no longer done in the most optimal way, such that the most effective treatments now do not get subsidized as much. With that said, let's start by talking about closing government. This team's logic would have you believe that we should let everyone get infected with COVID in order for COVID to become a big enough problem and there be enough deaths that the government decides to step in.
This logic is ridiculous. Their extension essentially boils down to, if this becomes a really, really big problem, people will get super, super sick, and then the government will decide to step in. A couple of responses. The first thing to explain is simply that the alternative that they are suggesting is the status quo. Like, they're like, we'll do no regulation, and then everyone will care, and we might get marginally better regulation. And the extent to which that is unclear surely means that this team must come last in the debate, because it is not worth the trade-off of getting hundreds of thousands of people sick. The second response is just to explain that this requires you to believe that there is no other way to reform the healthcare system, which is empirically untrue. There's been huge political will, especially in the growing awareness of things like the opioid crisis, to take active measures to ensure that people who are distrustful of the medical system, particularly in the wake of things like COVID, are more willing to get involved to improve things like access. See the policy that Joe Biden passed this morning, which is lowering the cost of prescription drugs and expanding it to particularly low SES areas in many American states. The third way to respond to this claim is just to explain that regulation and reforming of the healthcare system becomes harder after you introduce the problem of getting everyone sick. And that's because everyone is really, really way worse off. And the incentive to reform probably only applies to particularly rich electoral groups, or, the majority of people who previously had good access. The reason why people who are distrustful of the medical system or don't have access to the moment, like have shit healthcare, is often because they're really, really poor, which means even if you reform it, you won't be helping them, or they don't engage with it in the first place. So why would they engage with it now, particularly after the popularization of a whole bunch of quack remedies? But the final way to respond to this claim is just to say that it's actually incredibly unclear that you get enough people sick such that the government would step in the first place, because obviously not everyone in the world or the majority of people in society, as this government bench concedes, is likely to do this in bad ways. And so it's probably true that you get more people sick, but it's probably true that you don't get enough people sick in order to achieve your outcome. That's closing government done. Before I go on, opening government.
So in my speech, I pointed out that there are alternatives that individuals face. People have strong resistances or taking drugs that are harmful to them, and people are risk averse. This means that companies have to be able to get
Yeah. POIs can only have one premise. You said your first premise. I'm about to respond to it. So what does opening government do? Opening government have a few exogenous claims. The first is just characterization over how this is done. They give two pieces of substantive. The first is that it will just be a mindset change. A couple of responses. One, obviously there's a huge incentive of people pumping out newer remedies to try and discredit the medical system, which means that even if individuals in general want to approach this well, that is care about their health, they don't have the relative ability to discern between different pieces of information in order to ensure that they conduct themselves in a way that actually leads to the good outcomes. That is the missing premise here. Secondly, obviously individuals, as Matt explains, just opt into easier forms of treatment, which for the fact that they are generalized and non-specific means they're far less likely to be effective. And Matt uniquely explains why this increases the availability of bad alternatives, which just means on likelihood, the chances that people pick something bad increases. The second thing they say is that individuals are risk averse, and this will also address the POI. This is ridiculous. Individuals are less risk averse in your world. This is uncomparative for the reason that, as I explained, there's a huge discrediting of the healthcare system, which means that individuals now, for example, think that it's actually okay that anyone can take care of their health. Obviously, when you have a medical system that says we need expertise to do this, that's why individuals are risk averse. The second thing they say is that people go in for checkups earlier. One, if you believe their mechanism about current healthcare being expensive, then this can't be true, because getting a mammogram and getting x-rays and radiation therapy to detect cancer in early stages is incredibly expensive and something most individuals wouldn't think is worth it because they think they probably don't. But secondly, this creates a huge shift in discourse over who actually medical authorities are and who you should go to a checkup. That's the problem they never identify, because people, when they now care about their health more, don't just go to get a checkup from the doctor. They go to a bunch of random places that I explain give them bad, sets of prescriptions. The final thing they have is a principle on self-defense. One, not sure why this applies and why we should give the rights trade-off. If people get a lot sicker, that just might mean that everyone else has worse access to healthcare and diseases spread. But two, we already satisfy this principle to some extent. They never explain why the principle needs to be maximized. Let's talk about opening opposition. Problem with opening opposition is there is a black hole at the center of their case. And that is they never actually explain why regulation is so terrible that the worst forms of drugs are likely to be passed, which is what their entire case is premised upon. The analysis at closing opposition is far more nuanced, and we beat them in 3 ways. The first, as I explained in my introduction, our hunts apply to everyone by explaining that the subsidization mechanism is skewed such that drugs in general become more expensive, which forces people to get bad forms of treatment. Secondly, individuals are overprescribed to the extent that they now think that they constantly have a disease and actively go out and find alternative and more extreme cures. And thirdly, Matt breaks the deadlock by explaining what these drugs look like and why in our world we can still get the best cases of these because the incentive to make them exists, and why on their world you only popularize the worst instance of this. And breaking that deadlock uniquely allows closing government to better prove why there's mutual exclusivity in the harms that apply for opposition bench. For these reasons, vote CO.